Fine. Now we'll continue with our objective assessment. You know that objective assessment will have on observation, on palpation, on examination. On observation, you will have, I don't want to spend more time on this because you know all these things, built attitude of the limb, alertness, external appliances, pressure source, all these things you know. And I don't have much to tell you in palpation in neurological examination. We don't palpate much because palpatory assessment are most elusive assessment. It will give you a lot of illusionary information. Many patients, many physiotherapists will tell, I palpated the muscle tone, it was weak. That will mislead you. So palpatory assessment in neurological assessment or not that significant. In case if you have some edema or something like that, you can know whether it is a pitting or non-pitting edema, but that also comes in examination, it not as a purely palpatory examination. Next is the higher mental functions. The first on examination, you should see the higher mental function. So when I say higher mental function, 5 important things are there: consciousness, comprehension, orientation, attention, and memory. Very importantly, these things are there. In consciousness, we can say whether the patient is in stupor or he's in coma or he's in confusion. Based upon the GCS scores, you can say whether he is conscious. Next is comprehension, is whether he's able to understand whatever I am saying. Okay, I'm understand to inputs like auditory input or any visual inputs given to them. If they're able to understand and perceive that language, is called as comprehension. Orientation is whether he's able to communicate back, whether he is oriented to place, person, thing or not. Those things you know very well. Attention, in attention, is he able to give concentration to one particular sensory input for a given span of time? That is called as attention and attention span. This we are assessing simply because to know how alert he is and to what extent you can give him some intervention like exercises. If the patient is having a reduced attention span, like he has only for 10 minutes, your physiotherapy session cannot go beyond 10 minutes very effectively. You should know what are all the techniques to grab his attention back. So that is very essential. Memory is also a very important thing. It will give you an idea about what are the centers that are affected, on which memory is affected, and it will also give you an information about how complex exercises you can give, because how the patient will retain those informations. So all those things are going to be known. So when I say assessment, it is not only to know what is the patient's condition. Not most often people think to find out whether it is a Parkinson's or a Guillain-Barré syndrome or a peripheral nerve disease, but it is actually to know what are all the facetal problems the patient is having, wide variety of problems the patient is having. So based upon which we can frame our treatment. So the higher mental functions, which is most ignored part of physiotherapy management, is a very significant, has a significant influence on the management. Okay, and apart from that, you have the intellectual capacity, decision making, calculation, then the reasoning part. All those things are separate. They are also higher mental function. Next, what you have to assess is very importantly the perceptual deficits. If the patient is having apraxias, agnosias, aphasias, all those things, if the patient is having any perceptual disorders, which can localize the condition. For example, if the patient is having a Broca's aphasia, you can say that the patient is able to comprehend better, but he will not be able to express his ideas. That is called as expression aphasia, where you can say the lesion is in the frontal lobe, and you can say that the Broca's area is what is affected. In case if the patient is able to articulate things but he's not able to understand things, then you can say the problem is in the Wernicke's area, where it is called as receptive aphasia. So based upon that also you can localize lesion. But very importantly, you will know what treatment should be given and administered to the patient in case if the patient is having apraxia, which is nothing but difficulty in performing a skilled activity, which he has already learned, which he was doing before the stroke, but after that he won't be able to do a skill activity. Simply, for example, the patient doesn't know how to put on his dress. Okay, there are various types of apraxias, but not in the scope of the presentation. Next is the cranial nerve examination. Is a very important examination to localize the lesion, whether it is present in the brainstem or it is present in the brain or it is present below the brainstem. Because your cranial nerves, first two cranial nerves, optic and olfactory, olfactory and optic, arises from the brain. If there is any problem in these two cranial nerves, you can say that the problem is in the brain. In case if the patient is having any problem in the facial nerve, you can very well say the problem is in the pons. If it is on the same side, you can say it is on the pons. If it is on the opposite side, you can very well say that the lesion is just above the pons. And the examination of the cranial nerve is very essential in localizing the level of lesion. And also, very importantly, if the patient is having difficulty in swallowing, where there is a glossopharyngeal nerve involved, more than the motor rehabilitation of the limbs and the trunk, here the importance of re-educating the dysphagia is going to be very important, because if the patient is not able to swallow and drink, he's going to go for dehydration, he's going to go for malnutrition, and that is going to invariably affect the patient's motor performance very badly compared to the stroke as such. So you have to concentrate on that. Prioritizing your treatment can be given a clear idea when you are doing a cranial nerve examination. So, next is the motor examination, where you're going to do a reflex assessment. The deep tendon reflex assessment is going to give you a clear idea about where is the level of lesion. Okay, if the reflex is diminished or less, you can very well say that the problem is lower motor neuron. In case if the reflexes are diminished but other symptoms are suspecting a upper motor neuron lesion, you can very well say that because of the reflexes lost, then the patient is in case of a cerebral shock, or it is a pure cortical lesion. If the reflexes are high, then you can very well make sure that it is an upper motor neuron lesion, not a problem at all. In case of a superficial reflex, which is different from the deep tendon reflex, because superficial reflex are polysynaptic reflexes, whereas deep tendon reflex is otherwise called as a monosynaptic reflex. There is only one synapse that is happening in the deep tendon reflex, where there is a synapse between the sensory nerve fiber and the motor nerve fiber. Whereas in the superficial reflexes, like your Babinski sign, your abdominal reflex, your cremastic reflex, there you have various synapses. Okay, now I'll put you one direct question to you. Why you get a extensor plantar response when you are doing a Babinski sign? We say that Babinski sign is positive only when there is an extensor plantar response. Why we say so? Anybody? Why the toe is going for extension? Why it is not going for flexion in case of upper motor neuron lesion, but in case of a normal person it goes for flexion? Why is it so? Any answers? All these days you have been doing extensor plantar response, this Babinski sign. All your teachers might have taught you that there will be extensor response to the extensor hallux, or all the fanning of the fingers and extension of the great toe will happen. But why that happens? No idea? Okay. Yes, somebody is typing. Because pyramidal system is damaged and extrapyramidal take over. Okay. So what happens because of that? That's a good answer. That's a correct answer. So we say the extensor plantar response positive when there is a pyramidal involvement. So I told you that pyramidal system always have a influence on the flexor tones of the entire body, irrespective of the upper limb or lower limb. So when you give a sensory input from the sole, that is most sensitive part of the sole, this stimulates the somatosensory area, and in turn the sensory area responds to the sense information to the motor cortex, and from the motor cortex you send information down to the extrafusal muscle fibers by means of the pyramidal tract. If this complete system is intact, then only you will get a normal flexion response because pyramidal tract is dominating the flexors of the muscles. But in case if the pyramidal system is lost, if the pyramidal system is not functioning, this information goes to the cerebral cortex. So the cerebral cortex invariably will send information to the reticular activating system, and the reticular activating system will send the information to the extensors of the lower limb, and it will go for a fanning of fingers. Okay, so now we are testing the integrity of the pyramidal system. Why we are not doing the scratching on the upper limb? Why normally we do plantar response and grasp response in children, but we don't do this Babinski sign in the upper limb, because your ribrospinal tract is influencing the flexors of the upper limb, where you cannot distinguish whether it is a response from the ribrospinal or it is from the pyramidal tract. That is why we do it on the lower extremity. Got it? So in there is an extensor plantar response, you can make sure that there is a pyramidal involvement. In abdominal reflex, what we do, abdominal reflex, we test the integrity of the whether to see whether it is a lower motor neuron lesion or upper motor neuron lesion. If your umbilicus is like this, it is at the level of T10. Okay, so when I do a scratching in this manner, I am testing this right side. Okay, this is right side. I am testing T9 and T8, two dermatomal levels above the umbilicus. When I scratch this way, I am testing the left side at T9 and T8. When I do the one on the lower quadrant, I am testing T11 and T12. And here it is on the left side T10 and T12. T11 and T12. So if the reflexes are absent, then you can make sure that it is an upper motor neuron lesion. So this is not a much authentic reflex because there are studies which states that only 80% of the people have a normal abdominal reflex, and even in that 80% of the people, the reflex is diminished or not visible in case of people who have a big tummy, particularly in case of a male patients who have a lot of tufts of hair, and people who there is one more very significant study, people who lie down on their tummy also have a diminished reflexes. So it is not a much with which you can come to a conclusion that it's an upper motor neuron lesion. So most often or not, this abdominal reflexes are not documented in the investigation reports of patients. Only it is the extensor plantar response, that is your Babinski sign, that is assessed. So you can also assess the tone, you can also assess the voluntary control, you can assess the muscle power, and everything comes in the tone, sorry, motor system. So this voluntary control assessment is very useful when you are doing assessment for a stroke patients. Many people, I had a lot of argument with people who say functional rehabilitation and who are pioneers in the field of stroke rehabilitation, who go for muscle power assessment for stroke patients. What I argue is, in presence of spasticity, it is very difficult to assess a muscle power of an individual muscle, because you will not have an individual muscle performing. Most often you feel like whenever you ask the patient to do a wrist extension, the patient will do shoulder elevation and elbow flexion, and then he will try to do wrist flexion, and actually he will not be able to produce. So there is synergy which is existing. In the presence of synergy, it is very tough for you to assess the muscle power. You can assess muscle power if you have enough time to do that, but in a clinical setup, it is always better to go with a voluntary control assessment. So when I say voluntary control assessment, you should document whether the patient is able to initiate, sustain, and terminate the movement. So initiation, you need concentric contraction. For sustaining a movement, you need a isometric contraction, and for a proper termination of a movement, you need eccentric contraction. So you can test the three muscle activity types of muscle contraction by means of asking the patient to initiate, sustain, and terminate the movement. If you want to go for some more advanced things, you can ask the patient to move in diagonal patterns reciprocally, like supination and pronation continuously, opposite direction movements, and whether the patient is able to move against resistance, that is not a resistance given by the therapist, but a resistance which is offered in terms of an object or against the gravity or something like that. Because when it comes to stroke rehabilitation, the question of strengthening is less prioritized compared to the question of movement quality and control. Fine. So I will assess using this voluntary control pattern. Okay, this is I will do it for shoulder, elevation, flexion, abduction separately. I will do it for elbow separately and wrist separately, and know whether the patient is able to initiate, sustain, or terminate the movements. So you all know about coordination test. This was a presentation prepared for undergraduation. I really don't want to waste your time by means of telling you how to do the test, because now this is not about how to do a test, it is about how to differentiate. So you are going to assess next to motor system, you are going to assess the superficial touch, temperature and pressure sensation, deep sensation, and then cortical sensation. Whether you are going to do a cortical sensation or not is based upon your hypothesis. If your hypothesis says that this might be a lower motor neuron lesion, then you will not do a cortical sensation assessment. You got it? If you think that this patient is a Parkinson patient, you will not do a muscle power examination or a voluntary control examination. There you will do a examination of the movement time and the reaction time. So based upon what we are going to assess is dependent on our hypothesis, what we suspect. Next is the musculoskeletal examination, active range of motion and passive range of motion. This most of the people ignore in case of neurological examination. If I have a full and free passive range of motion, but my active range of motion is limited, then I will say the problem is with the muscle or the control mechanism of the muscle, where the active range of motion is diminished, but the passive movements is fine. But in case if I find a patient with both active range of motion and passive range of motion limited, then I will blame only the joint structures. It might be a joint stiffness or a muscle stiffness. It is more of passive problem rather than an active problem. There are also instances where the active range of motion will be full and free, and the passive not full and free. The passive range of motion will be more than the active range of motion will be more than the passive range of motion. This can happen when the patient is having an apprehension to move. When the patient thinks that bending forwards will result in, if somebody do this movement, I will fall. If I do on my own, I am fine. Even in the shoulder elevation also, if the patient is having severe shoulder impingement syndrome, the patient will be reluctant when somebody is moving the upper limb. They will have a lot of apprehension. But when the patient is performing, he knows until when he can lift and where he will get pain. So he will be doing it. So very rare scenario this when there is a pain or apprehension. So active range of motion and passive range of motion are very important. And then you have you have to give perturbations to all directions to see whether the patient is okay. So the static balance will is to integrate three sensory inputs. One is visual, another one is the proprioception, and the third one is his vestibular system. So these three inputs are very essential for him to do a proper balance. This is a dynamic balance where the patient asks him to turn to various sides without much disturbing the line of gravity and the center of gravity. Now the patient is giving him a much more difficult dynamic task to perform, where he is going to displace his line of gravity more compared to the previous two tasks. making him to reach within arm's length, and now she's going to make him reach beyond the arm's length. Can you see this? So this is advanced balanced dynamic balance testing. I mean to say advanced because test is not advanced, but the efforts required from the patient is more advanced. So first you ask the patient to reach within arm's length, then you ask him to reach beyond the arm's length. First ask him to reach forwards and then give him reaching towards the lateral side. Give him reaching with the normal hand and then give him reaching with the extended hand. So all these things are tests for assessing the stability. So in case of you can use a belt. So that belt can help you in holding whenever the patient is falling. In Indian scenario, I normally use a towel to be tied in the patient's waist, and I just hold the towel so that I'm not giving a direct support to the patient, but at the same time when he is trying to fall, I will hold on to him very nicely. Test the balance in standing also, the same pattern how you have tested in sitting. Apart from that, ask him to stand on single leg and see whether he's able to do or not. All these things are balance testing. So there are some tests like functional reach test which you can perform to know how far the patient is reaching. It can be done in the frontal plane as well as the sagittal plane. There are a lot of variations. Okay, so these tests you can use to assess the balance. Symmetry of movement is very important. Postural strategies, hip strategy, ankle strategy, stepping strategy, all these things are very important in localizing the lesion. When you have a gait abnormality, you have to assess for gait parameters. You have objective assessment of the gait and subjective assessment. The objective assessment is always quantitative. When you are able to quantify the stride length, step length, the stride width, the toe out, okay, cadence, gait velocity, all these things are quantitative measures which can give you a numerological value. Okay, and the direction of propagation is also one. You can see that these things differ in individual stroke in individual neurological patients, the gait quality and quantity. You have fascinating type of gait in Parkinson's. You have ataxic gait in cerebellar lesion. You have circumdactory gait in case of stroke patient, where their hip flexors will be weak, because of which they will be using their abductors, and all these things will give you a clear idea. Finally, you have to go for a functional assessment using some tools, which is always better to give some numerological values, like case of a Barthel index or a functional independence measure. So after this, you are coming to a problem list. Okay, the problem list should be hierarchical using technical terms. I told you that the chief complaint should not have any technical terms, but the problem list should have technical terms. What problems you can treat should only be in the problem list. If the patient is having some ocular management, like the patient is having diplopia, if you don't have any treatment for that, as a physiotherapist, don't include that in your problem, because you are not going to give any solution. If the patient says that I am getting palpitations often, if I'm getting a sort of a cardiac symptoms, then don't prioritize in your problem list. Refer the patient to a concerned doctor. So what are all the problems you can give solution should be there in the problem list. After the problem list, devise the goal setting, divide it into short-term and long-term goal. This, according to me, is only having conventional value, but sometimes it helps people, but I don't prioritize them on a long-term and short-term goal in case of a neurological condition where you don't know the prognosis of the patient. It may be true in case of an orthopedic assessment where you can actually judge how a post-operative patient with ACL reconstruction or an osteoarthritis patient is going to progress. But in case of a neurological condition with a lot amount of uncertainty, I really question this people's attitude, people's action of doing short-term goal assessment and long-term goal assessment. And again, that is beyond the scope of this presentation.